Good evening. Thank you so much for attending our event. My name is Renee Angelis, and I'm with the Arthritis Foundation. In the back, I have Jennifer Doherty. She's my counterpart at the Arthritis Foundation, and it's our job to sit here and make sure that we give you resources. We're not sitting anywhere, actually, but to make sure that we give you resources so that you can live your best life. You can visit our website. We have got an amazing event planned for this evening. I want to also thank Spooner for hosting our event. It wouldn't be possible without Natalie and all of Spooner's help, as well as Arizona Arthritis and Rheumatology Associates with Dr. Sharobeem. Thank you so much. Hopefully you know them. If you don't, you're going to get to know an amazing panel here of expertise. And please, while you're getting those questions, I know that Natalie, I'll be turning it over to her in a little bit. But we do have a couple events throughout the year. So I hope that you will join us, whether it be our Walk to Cure Arthritis, whether it be our Jingle Bell Run that's coming. We also will be having patient education going on throughout the year and all around the valley. So if you like this, let us know, and we'll make sure that we plan some other resources that you can get information and connect with our experts. So at this point, I'd like to turn it over to Natalie Black with Spooner. Hi there. Thank you.
I'm the same people I talk. Oh, I'm trying to think. We're using these because we have lots of friends with us virtually today.
So is it good, Andrew? Okay, great. Hi, everyone. I'm so glad that you're here. As Renee said, my name's Natalie, if you don't know me. I know a lot of faces in the crowd, but a lot of you I don't know, which is super exciting because I'd love to meet you. I am an occupational therapist. I work here at this clinic for Spooner. I've been here for 5 years now at this location, which is super exciting. I am very passionate about chronic illness, treating patients that have EDS, POTS, MCAS, et cetera, you name it. And one of the things that I love the most is bringing people together within the EDS community so that you are able to meet each other. And I think I said this last year, we did host this event last year, a smaller version of it as far as those of us who are here talking. And I'm so excited that so many of my friends and colleagues have decided to join tonight. It's a huge honor for me. But I said this last year, the main reason why I wanted to do this type of a thing in the first place is that so that you amazing people would have the opportunity to meet other amazing people like yourselves, because there's such a lack of that in this population of people and the people that are dealing with these different types of diagnoses that you are dealing with. So it's really important to me that you feel heard, valued, understood, and that you're able to seek community with each other and community with us. I also think that a lot of times medical professionals have gaslit you in the past, most likely, or that you've experienced some sort of a trauma around that. So it's an opportunity for us to show you that at least some of us really, really care, value you, love you, want to listen to you, want to validate you and support you in what you need. So all that being said, I hope that you have that experience tonight. What we're going to do this evening is that one at a time of us are just going to kind of tell you a little bit about what we do as a practitioner, the services that we can provide, maybe a little bit of our experiences working with the EDS population. And then after that, we're just going to turn it over for questions. You guys have a QR code. That way your questions will be anonymous as I read them out to the crew. And also I can kind of like facilitate and make sure that they're questions that are going to be really helpful for everybody here to spend our time talking about. You can pose a question to any one of us individually, or you can pose a general question. That would be really helpful too. After that, we'll leave some time for you guys to like mingle, talk to each other, and also to come up to any of us to ask specific questions and to meet us. We'd really love to meet all of you that we don't know. What else? Okay, so does all make sense so far? I don't think everybody was here. Also, I'm sorry when I made the announcement about where the restroom is, but it's right outside that door across the hall, and there's water right over there by the big S on the wall. Okay. So really briefly, all that to be said, a little bit about me. I'm an OT. Like I said, I specialize in treating chronic illness, specifically EDS. And what that looks like can be very different from therapist to therapist that you work with. I'm sure a lot of you have been treated by a physical therapist or occupational therapist in the past, or maybe currently. Within the realm of the outpatient treatment world, meaning, you come here, you do therapy, you go home, there's quite a lot of overlap between OT and PT. So a lot of my patients, I would say maybe the majority of my patients, tend to think that I'm a physical therapist because I treat very much like a physical therapist in many ways. That's because I use a lot of manual modalities. I do a lot of strengthening with my patients. But the OT perspective that I bring to my patient care is really one from the mental health perspective and the emotional health perspective as well. So that's super important to me. I really strive to create an environment where my patients feel safe and like they can bring up anything in their life to me and that we can troubleshoot together to help. So it goes well beyond just physically strengthening your body, although that's obviously super, super important. But I really try to make it so that we can talk about how your emotional perspective, your mental perspective, your neurodiversity, all of these things impact the way that you feel and you function on a day-to-day basis. The really intricate areas of specialty that I really like to treat and bring to my patients are pelvic floor therapy. So we do a lot of that. Most of my patients that have EDS have some level of pelvic floor dysfunction. So that's something that we work on together and that I'm certified to treat. I do a lot of functional dry needling with patients, which if you haven't experienced dry needling before, it's a really great form of manual treatment that can help you with your muscle tension and all those types of things. And then like I briefly mentioned, working with patients from their psychosocial standpoint and helping them to kind of understand what's going on with their body, the reasons why it might be going on, and really just bringing that education piece that a lot of people feel like they're missing on a one-to-one basis with a provider. What else? I feel like that's a little synopsis. So I'll pass it over to Andy. We'll obviously come back with any questions, and then I really look forward to meeting all of you as well.
Yeah. Good. All right, cool.
Do I hand this to Andy?
I have one.
Oh, okay.
I'm special.
Dr. Sharobeem.
Thanks. I feel bad standing in front of you guys, but
I got referred to him.
I love it. It's a Jersey thing. But thank you all for making it. It really means a lot that you actually made it in person, and those who are virtual, we appreciate your presence as well. Well, first, let me thank Arthritis Foundation for making this all happen. It truly wouldn't have been this much of a success without the support of you guys in the panel, so we really appreciate that. And of course, Spooner for hosting, and Natalie always kind of spearheading all the logistics as well on this end. And of course, thank you to all my colleagues for showing up and making this what it is. And showing up means that they care. So it means a lot to me, and I'm sure it means a lot to you guys too. That being said, my name is Andy Sharobeem. I'm a rheumatologist by trade. I was working out in New Jersey for a few years before I moved out to Arizona. When I first started hearing about Ehlers-Danlos and being exposed to it, believe it or not, it wasn't necessarily in med school. Surprise, surprise. In medical school, as I always joke, they give me a little paragraph to read about Ehlers-Danlos. Usually it's just about vascular, which is just as important, but it's only about vascular, and then we move on. So we never talk about the nuances. We never talked about the proclivities and the issues that arise throughout lives of patients who have EDS. So it's very unfortunate for all medical students coming out the gate that they don't have an understanding of what this could mean for somebody, and they don't have the awareness enough to even notice it in clinical practice when it comes to their door, right? So how I was exposed at first was the late, great Dr. Gall, Eric Gall from the University of Arizona. That's where I did my fellowship in rheumatology. And he always drove home the idea that anybody can have EDS, It was almost like a mystery to me because I never was exposed to it, but he was always an advocate. He was always pushing for it. And so I decided to humor the guy because at first I was like, okay, they're double jointed. So what? I was like everybody else, right? Unfortunately. But I kept going into these to the patient, and I would look for that. I would first do the Baton or Biton criteria and whatnot. And then I'd see that, a lot of people are double jointed, but that's it. That's all I'm getting. And then he would push me further and say, you know what? Now ask this and ask these. And these are obviously the questions that you ask when you're looking for chronic pain, when you're looking for POTS, when you're looking for mast cell or histamine issues, all of the above. And so I started asking these important questions, and I realized that this is a thing. This is here to stay, and nobody knows about it. And to me, that was shocking. I was like, I didn't even know about it. So I decided to make it my thing. And it became almost like a fixation. Type A neurotic. So I became a fixation. I started reading like crazy about it. And I started trying to understand my patients, putting myself in their shoes. And although I cannot feel them fully, I started realizing how annoying it is to live with EDS, but to also be told that there's really nothing wrong. You know, go home. I can't do anything about it for you. Go to this person. They might be able to help you, and they don't. So, and even in the same families, you know, even in your own family, some people may not manifest the way you do. And some of them might just gaslight you as well. It's the sad truth. So for me, I decided that I didn't only want to be aware. I didn't want to only look into it and diagnose it and try to validate it. I also want to be an advocate for all of you. So that way I can at least raise the awareness and at least be one cog in the wheel, even if I just affect a few lives a day, so that that awareness is spread, as you know. And that way we can bring that awareness to the medical community at large, and then have that be a thing for the medical community and not just my thing and not just your thing. Does that make sense? I keep saying thing because I'm from New York and Jersey. So the thing is going to keep coming out. So I'm sorry. But long story short, I came to Arizona. We built an awesome team here. And what we found was missing was that niche of doctors that just diagnose. We forgot all about that. We see so many patients. I have POTS and mast cell. So what? I'm like, did you not know you had Ehlers-Danlos syndrome that could be tied to this? Most people do not. So unfortunately, that was what the missing piece was to us. So what we did was we just filled that niche. At first, I said, come one, come all, right? And unfortunately, that did not end well for me. I was inundated, unfortunately. I wanted to help everyone, but I'm just one person and my team, we're just one team. So unfortunately, we had to take a load off, if you will. We had to make sure that we were doing right by the community, because once your doctor is burdened, useless to you. So we didn't want to be burdened because we wanted to excel in our craft. So what we did was we formed, and it was a labor of love, and I'm obviously going to introduce my coworker and colleague soon, a roadmap. And what we decided to do was fill a niche of the people that validate, confirm, and direct your care, but also try to form what the EDS Society is forming now, which is centers of excellence. But we tried to do that in a way where it's community-wide. Instead of in a building, we decided to bring in the community, bring in like-minded individuals, practitioners, allied healthcare professionals, and every subspecialty as we can, to allow them to also shed that, spread the awareness, and also help our patients in a way where no one is burdened. That way you have all these cogs in the wheel, and you are the center, right? So therefore, every specialist has their part and role to play, and you are in the center. And therefore, you can get efficient care, and therefore you have compassionate and passionate care, and no one's dropping the ball because everyone knows their place, and they know that you are in the center, and therefore you are the most important, you are VIP, and you deserve that care because you've been spending decades of your life just unnoticed, and gaslit by everyone. And that's not fair to you. We should do more. We should do better. So that is kind of my trajectory. That's where I'm at today. I hope that all made sense. I know the thing got out of control, but I think we're past that. And I truly am honored and blessed to have you all here and to be in your presence. Also, everybody behind me, I'm sorry. I would do a little jig and a dance, but that's for later. I don't sing, but I could if you want me to. But thank you all for your attention. And seriously, it means so much to me. It touches me. And I want you to know you're all very important to us. Okay. Thank you. And who am I? Lindsay. Okay. And without further ado, this is my coworker, colleague, esteemed, confidant, and the person whose labor of love is the EDS roadmap. She is the CEO, the founder of it, Lindsay DeWolfe.
Hello. Hi, everybody. So I'm Lindsay DeWolfe, nurse practitioner, colleague to Dr. Andy Sharobeem. We've been working together for about 2 years now.
Sorry.
Oops, no.
What's your thing?
It was green. It gave me the green, man.
Oh,
I'm green.
Yeah.
And
okay, sorry.
we're good? Oh, okay. Sorry.
Making sure people at home can.
Right, absolutely. So, yeah, working together for about 2 years. I didn't know anything about EDS when I joined Dr. Sharobeem. He took me under his wing, taught me everything I needed to know about it. And he was kind of a mess when I first started working with him. But basically, I took over, organized everything, got everything written down. And then the roadmap, if you will, grew from there. Basically, it's updated, weekly to monthly, depending. But it takes a lot of research and meeting people and it's a work in progress, but we continue to try to improve it, and it changes all the time. But so the way I approach patient care is that first of all, if you have an appointment with us, you're going to meet me first. I like to ask open-ended questions, kind of let you lead the appointment a little bit. I like to hear the story. I need the story. It helps me to understand where you're coming from, what you've been through. All of that is important to how we're going to guide your care. So that's the most important thing when approaching patient care. So thanks for having me tonight, and I look forward to any questions.
This far, so I'm just going to run the information.
Oh, that's okay.
Okay.
So like that.
Yeah. So I'm Dr. Nielson, Jason, Arizona native. I don't know how many are here from Arizona. Went to the University of Arizona as well. A little bit about myself. I did a lot of sports. I was training for the Olympics, 96 as a cyclist, and I just had injury after injury, tendon repair, replacements, multiple surgeries. I decided to go become a chiropractor about 22, 23 years ago. And over the last 6 or 7 years, I started having more joint pain, tendon problems, additional surgeries, hand surgeries. And then within the last couple of years, I started having neck surgeries. And one of the other doctors like, hey, you might have this issue. And I'm like, I don't know, maybe. That's why I started doing some research. I'm like, I fit all the categories on these. And got in touch with Dr. Sharobeem in his office. And he said, yeah, you got it. And we can do this and this and this. And I'm like, well, I can do that at my place. What about chiropractic? He's like, yeah, if it works, go ahead and do it. And so I've did my whole career over the last couple of years to preserve my joints. So I know when my patients come in and I talk to them, hey, you got this and you've got this, and you probably have this, and this is what you're going through. And then I tell them I have it and I can relate to you. And a lot of those times that they just start to cry up and tear because they understand that somebody can know what they're going through, and they've been down this route, and they think they've made it up. It's in their head. They can't correlate with anybody. Nobody knows what they're going through, or the chronic pain or the weather pressure and those types of things. So I know what you're going through. I know the discomforts, the joint pain, the joints when they pop out and you're trying to put them in and trying to work with a patient. And I do an adjustment on a patient and my joint falls out. I'm trying to hold it. I'm like, all right, let's go out to the clinic here. And my staff's like, what's going on? I'm like, gosh, dang it. So I know what it's like. So over the last couple of years, I've changed my path and kind of went back and did some research in neurology and spinal rehab so I could do intraoperative neuromonitoring and work with neurology cases that would preserve my joints. But I still work with the EDS community with my patients. And when I see them, we work with it from a standpoint from pain management. So I work with them from a chiropractic conservative treatment. And if we need to work with them to go into some nutrition that might be a little bit more specific, we can do that. Educate them on what they need to know. And then is it pain management for injections or whatever it might be? It's not always narcotics. And that's kind of the misnomer with this pain is we'll give them a pill, but it's not always that. So I work with a lot of pain doctors across the valley in our group that I educate them. This is what we have. This is the patient. This is what I think we should do. And can we work with them that way? So it's been a great educational standpoint from what I do in my practice. From chiropractic, same type of thing. In school, they say, here's EDS, and it's a vascular issue. Don't adjust anybody that has vascular issues because you're going to stroke them out and have a problem on your hands. Okay, we'll just stay away from it. And as the more I researched into it, I found that it's just a subcategory. And unless you know what's going on and how it works, there's certain things. For example, hypermobility. If we keep adjusting that hypermobile segment, it's not going to get better. It's going to feel great, and then it's going to come right back. So we look at ligament instability and how do we manipulate that joint or that spine to get it moving, but without compromising the ones that's hyper at that point in time. So that's kind of what I work with and kind of get that treatment back into plan. Then you throw in this other condition called POTS, and how do we work with that to stabilize somebody that's deconditioned, and anytime they get up to do something, a vacuum or reach a plate, they get lightheaded and dizziness. And how do we get that back to build up those systems in the body so that they can have the strength and stability so they don't get lightheaded and dizzy and can then move forward and prevent that and have a normal life of just walking their dog or walking with their spouse or their kids without getting lightheaded. So on some of those types of cases, I send those back over to Spooner for physical therapy because they've got the dedicated team to work with it, where I can kind of work with them on a different standpoint and we'll communicate back and forth. So from chiropractic, I know what you're going through. I've had to change and step back and do a little bit more different in my career so I can preserve myself. So I'm not going to fall apart. I do have braces that I wear. I do have my own routine that I try to do at home just to kind of preserve so I can reach as many people as I can and work with and help you understand that you're not alone out there, and there is somebody that can help you, that knows what you're going through and can help target that treatment plan just a little bit better. So I'll leave that and questions later.
Hi, my name is Rebecca Schaffer. I'm a dentist. You don't have to all get up at once and leave. I'm also an orofacial pain specialist, and I'm the only orofacial pain specialist in the Valley that still does general dentistry, and I subspecialize in EDS. But I also want to tell you how lucky you are tonight. You have not just one person who was born and raised in New York City and then worked down the Jersey Shore. You have two. And it turns out we worked at the same hospital for a while. I won't tell you what we think of that hospital, but if you're ever in Western Monmouth County, don't go there. So we can make a lot of Jersey jokes. You know, well, you don't know what you're missing. Jersey's great, okay? Bruce Springsteen can live anywhere in the world that he wants to, and he moved 10 minutes from where he was born. So much for Born to Run. Anyhow, I've been working with people with complex medical histories for my entire professional life, and even before that. It's something I've always done, always wanted to do. In New Jersey, I had a mobile practice. Life brought me to Arizona, mostly because of my husband's job. And I teach at the dental school in Mesa. And I decided that orofacial pain was what I wanted to do. And so I will tell you that I got my board certification the same week I became a grandmother. So lifelong learning is a good thing. I don't want to repeat what all my great colleagues have said. I understand that you folks have been gaslighted. As a woman provider, when women come to me and tell me that every other doctor has told them they're crazy, you have fibro, go home, take care of your husband, lose weight, there's nothing wrong with you. I had a new patient today with that. It makes my blood boil. Some of you are my patients, so I really do care. I also treat people with bleeding disorders. So, and there's a lot of overlap and misdiagnosis between von Willebrand and hypermobile EDS. And I understand that there's a lot of bleeding issues. So with all due respect to everybody else, I take care of the only joint with which you cannot live without. You can live without your knees. You can even live without your hips if you had to, not well. You can't live without this one. And it's really special because they're two joints that have to work together. They have no choice. When you have EDS, the chances of having a dysfunctional temporomandibular joint, the studies show vary from 80 to 100%. And a person with EDS who has temporomandibular joint dysfunction is different from a person with TMDs who doesn't have EDS. So that's why I've kind of zeroed in on this, because like everyone on the panel, if you're lucky, it's one paragraph in medical and dental school. But when we see people who have been gaslighted and dismissed by the medical community, we're very honored to be able to make your lives better. One of our colleagues, Claire Franconimo, she just wrote a paper on how people with EDS have like micro PTSD. Did you look at that paper? And it comes from repeated, very negative interactions with the medical system. So it's a real thing. And I'm really honored and proud to be here and to work with this team. I can't do my job without these guys. But your TMJ symptoms are very real. And when a joint impacts your ability to eat and to chew and to speak and to smile, there is help. But again, EDS is a very specialized thing. So for me, I can't just worry about the joint. I have to worry all the way down to the pelvic floor, the cervical instability that creates the migraines, and even in some cases, trigeminal neuralgia. We understand how the vagus nerve, which is the nerve that controls your your ability to digest and breathe and control your heart rate. When you're in chronic pain, the dysautonomia affects everything. And then changing hats slightly, I still do general dentistry. When you go to the dentist, and they give you the regular lidocaine, and you tell them I'm not numb, and they tell you you're crazy, and why can't you get numb? It's your fault. Leave, okay? Lidocaine just doesn't work. There's another local anesthetic called Articaine that works better, still only 88% of the time. And I've asked the Brain Trust, international, the people who know everything, and nobody knows why. No one's done the research on it. Nobody understands why lidocaine doesn't work when you go to the dentist. Articaine works pretty well most of the time. And some of you who've been unfortunate enough to have me drill some cavities, there's a checklist that's part of a presentation I'm going to be doing in Philadelphia that's meant to empower patients. I'll make it available through you, and you should just bring it with you to your dentist, check off all the things that affect you. And if they look at it and they take you seriously, stay. If they look at it and say, I don't have time for this, just get up and leave, okay? So that's my two heads. I still do general dentistry, but my real passion is orofacial pain, especially people with any kind of collagen or bleeding disorders. And so if you have any questions, let me know. And honestly, Natalie has taught me more about how to treat temporomandibular joint dysfunction and EDS than I've taught her. And she's amazing. So we can make a couple more New Jersey jokes, but New Jersey is a great place.
Is this thing working?
No.
Here, take mine.
The button.
Push
No,
this
he's
button.
got one.
Oh, you've got one. You got to make it green.
So it goes green. Keep going. There we go.
Oh.
Turn yours off.
Avocado, cheese stick, apricots, gluten-free. Hi, everybody. About now.
Don't just stand up like that.
Just, all right, all right.
You don't have.
Well, I'm standing now. Thank you. So yeah, long story short, had some people who got me down this pathway and graduated naturopathic school, SCNM in 2014. Had a rheumatologist pick me up off the street, old warhorse Paul Howard. And so my big interest was the intersection between musculoskeletal disease and the immune system. Very, very complex, interesting diseases. That got boring because biologics came out, right? And with the exception of some of these diseases, pretty easy to treat. And so, I don't know, maybe I put out some I'm bored kind of energy wavelength. And then these people who I learned about from Sharobeem, kind of Gumby, could do parlor tricks with their joints, started showing up. And I took in.
Knows who Gumby is.
What?
Ask if they know who Gumby is.
Do you guys know who Gumby is? What's the horse's name? Hokey. Yeah, and the blockheads, right? Yeah, good stuff. And so I took a lot of interest in these people, and I didn't really have an appreciation for how far down the internal medicine rabbit hole you could go with them. And they'd come in and they'd have this problem list that was like this long in size 10 font. And I'd look at them and they were on 7 different medicines and they had seen 20 different providers. And I'm like, wow, what's going on here? Tell me all about this stuff. And they looked at me like I was crazy because they're like, who's this guy who wants to hear all about it? And so the first couple years in working with them, I really had no idea what to do for them other than just kind of be a cheerleader and get them plugged into the right specialists. And I'd send them here and there. And a lot of the folks that I run into seem to have allergy-mediated issues or immunologic issues, which is my biggest interest with these folks, which a lot of you have heard the term mast cell activation syndrome and that spectrum. But what's really challenging about that is we don't have great guidelines, and there's a lot of trial and error and a lot of different styles out there for approach. And so, and really all of these individuals are very different in how they present. So outside of where I originally began with interest in rheumatology, where you're kind of looking at the whole person and all these different organ systems, you have to look at these EDS patients in the same way because the immunologic aberrancies that they may have can cut across multiple organ systems. And so they can be very challenging. And so you're trying to prioritize, and I like what was brought up about this micro PTSD and the challenges that a lot of these patients face in the medical system, because I'm constantly thinking about, as I'm sending patients out for all this other workup that they can have done, to have all these scans and studies done, what is the worthwhileness or utility of that? That's just one more pathway that they could go down that costs a lot of time, costs a lot of resources. They could have another bad medical experience. Okay. And so it's kind of sorting through a systems approach, hitting the highest yield specialties that you think may be involved for the pertinent case. The other thing I'll say is this: it gets really complex when somebody has more than one thing going on. So we tend to get tunnel viewed. And I saw this a lot with the rheumatology patients. They come in and they say, I have lupus. And I say, so what? You're on Benlysta, hydroxychloroquine, steroids, 5 other medicines. Do you really care about lupus anymore? Something else may be going on. So you can have EDS, superimposed autoimmune disease. You can have endometriosis or thyroid disease on top of it. You can have nutrient deficiencies. And so that's kind of my approach. And thanks, Natalie, for helping out with a lot of these patients, because outside of the internal medicine domain, I'm not a mechanic, and I'm like, don't ask me about your leg length discrepancy or pelvic floor. And thank you too. Some of these patients that need heavier duty medicines, they've been of great help. So yeah, it's a really nebulous topic, but I think there's a lot of work being done, and there's a lot of great people out there that I've been able to team up with. And a lot of you patients are very inspiring to me. I sat down with a young gal this morning, just graduated with a 3.97 GPA. She can hardly get out of bed. She's got POTS, crippling pain. She's on Symphony, IVIG, all these different medicines. And she's like, how did I do that? And I was like, because you're amazing and you're very resilient. And if I was in your shoes, I probably would have got like a 1.6 GPA, but all right.
Thanks, man.
Okay, so now I'm talking into this thing. Does that work? Okay, so prior to going through some questions, I've promised two of our other colleagues that I would share something on their behalf to you this evening because they couldn't be here. One is Dr. Emily Rich. You might know her from Instagram. If you don't have it, I'll pass it along. I can't think of it right now, but I think it's Emily Rich OT. She's a therapist in Tucson. She specializes in treating POTS. A lot of us work with POTS patients, of course, but that's like her real true specialty. She was hoping to Zoom in this evening, but she had something come up with her baby. So if you don't follow her Instagram, she's an excellent resource. I would love you to follow her Instagram. I'm not active that much on Instagram as far as my profession goes, but she's a fabulous resource for that. So if you don't follow her, please do. I'd be happy to get you in direct contact with her as well after the event if you need her information. And the second person, please pay attention to this one because it's so fabulous to me that this person had a desire to share with you. Unfortunately, due to some circumstances, there was kind of like a conflict of interest in her being here tonight, which I'd be happy to explain in person if you needed to know that. But she is a therapist, a psychotherapist, a counselor who is amazing. Her name is Elizabeth Freese, Beth Freese, Freese. She specializes in treating chronic pain and PTSD. So she has a lot of patients like yourselves that come and see her and work with her on a regular basis. So I really wanted to put a plug in for her too, because she's fabulous. If any of you are looking for somebody to talk to, that could be really helpful for you. Okay, so now maybe everybody like stretch your legs out for a second, stand up if you need to for a second. And then if you have any questions, please scan the QR code and send that in. I have some questions we'll get started with right off the bat. Sound good? Nothing is off the table, so please scan questions in for us. I stay sitting. Okay, awesome. We have so many great questions. This is so exciting. So we're going to start with a few that you guys typed in when you were signing up for tonight, and then we'll go through some of the ones that you're sending in now too. First question that I love: should people with EDS be seen only by providers who have experience with our condition? Anyone want to answer that? Andy, I feel like that might be you. Yeah.
Yeah, no, it's an excellent question. The issue is that there's so few and far between the ones that advertise themselves, meaning that they're either concierge docs that you can actually call and get consults a few states away, or ones that are local that advertise themselves as knowing a thing or two about EDS. That is extremely rare relative to the medical community as a whole. So what I can say is that sometimes, unfortunately, and I hate to say this out loud, you have to take what you can get at first. You got to just get your foot in the door. And then that's when the advocating for yourself really ramps up to high gear, because that's going to mean which way you go with that practitioner or the ones that they direct your care towards. That's when you start fighting for yourself and not taking no for an answer and not giving any more second chances. Unfortunately, it happens a lot in the medical community where we're like, okay, yeah, it was an okay visit. You know, maybe they just don't know if they're going to go home and read about it. I'm going to see them a second time, third time, but they looked at me like I had 10 heads. And that's already a bad sign. I mean, you can't really waste your time doing that. But I can tell you there are just passionate human beings that are doctors. So if they are willing to take it on and say, you know what, I don't know much about it, but I'm willing to learn and I want to help you, please stick to that person. Do not just go find that person that's literally on billboards or, you know, you got to pay $1,000 to see on a virtual consult. They're like halfway across the world. You don't have to scour and look for those people because it's going to take a while to see them. By all means, get that appointment in because you know they're specialized in it. And if they are a year out, get whatever you can in the meantime and see if that person is, you know, passionate and compassionate enough to be there for you. Hold your hand through that process and guide you as much as they can. And after that, it's hopefully you get to where you need to be. And therefore, you kind of use the medical system in a more efficient and systematic way, as opposed to always waiting for that EDS specialist to see you, which a lot of times it's not as fruitful as you may think. But that's my answer. I hope that makes sense.
To kind of tag along with that question, one of you messaged in that if a patient were to see more than one of us, would we be in communication with each other about that patient? And that is a resounding yes. I think a lot of you are patients of multiple of us who are here this evening. And if you're just a patient of one of us, maybe you find some other resources tonight, but we are in communication about you guys behind the scenes when it's necessary, and in a HIPAA compliant way, of course. So that was a great question. And yes, if you see one of us, we will take it upon ourselves to help manage your care comprehensively. We've had a few questions come in about gastrointestinal issues. Curious about GI symptoms / do you recommend any diet protocol for GI symptoms? Billy?
Sure.
Billy, Chris.
Gut health, that's a big one today, right? Okay. So a lot of these patients get tacked with the vague irritable bowel diagnosis, which is a syndrome that could mean a lot of different things. You know, so the gastroenterologist may, you know, treat you according to the pattern: constipation, diarrhea. There's actually a lot of off-label medicines that can treat those things better than what the gastroenterologists do, in my opinion. But I think the big question was about diet. Was that what was wanting to be known about? It's a little vague.
Yes, it is. Let's go with maybe typical GI symptom presentation for a patient with
bowels all over the place.
Yeah.
I'm constipated today.
And
I'm burning through the toilet paper tomorrow. Yeah, back and forth. Okay. So
protocols.
diet protocols. Diet's tricky. And let me preface by saying that you should look at diet as a medical intervention with risks and benefits. So what I mean by that is some people start with cutting out gluten, then goes to nightshades, then goes to broccoli, then goes to carrots, then goes to rice, then goes, and they come in and I'm like, my dear or sir, you've been eating nothing but meat for years or chicken and rice. Now we got to work with nutrient deficiencies. Now we have to work with fear of eating certain foods, being underweight, hormonal imbalance from that. So please involve at least have your primary care watch you so you can work with them as as your springboard saying, hey, is this really bothering me or not? Maybe they could help you sort it out, or a nutritionist. Beyond that, though, yes, some people do really benefit from diet. The problem is there's 50 zillion dietary approaches out there, but I'll break it down for the EDS specific patients. The ones that the two dietary approaches that I've seen most helpful is low FODMAP. Have you all heard of that? FODMAP? Who wants to tell me what the acronym means? Fructans, oligosaccharides, disaccharides, monosaccharides, and polyols. They're fermentable carbohydrate chains that we don't break down very well. And all the bacteria in our GI tract eat it first. And they burp and fart. And that causes problems, distension, bloating, increased motility, decreased motility, constipation, and diarrhea. A lot of EDSers have what we call SIBO or SIFO. Okay. And so regulating your FODMAP intake can reduce symptoms. I used to use like a gold standard Olympic approach where I'm like, here you go, take these 40 different things out of your diet. I learned very fast that didn't work. So what I'm doing with patients these days is I say, study this list, first just surveillance your diet and see if you notice any symptoms. Keep a little log, write down your GI symptoms, rate it 1 to 4, 1 minimal, 4 worse, and pay attention. If you can't figure it out and you need to do a washout, take it in pieces. Work on the fructans today, put them back in over 2 weeks, the oligosaccharides tomorrow, the disaccharides, so on and so forth. And then it's the same thing with histamine dense foods. Okay. Somebody groaned in the audience.
Yeah.
Don't go to Sharobeem.
Yeah. Are you telling your patients to rip out all the histamines?
I'm trying to help them survive until they see you.
Hey, yeah, it could be magic though. And the histamine dense food list is much more extensive, right? So, I mean, those are the two big things. Talk to your providers, make sure somebody's monitoring you. And if it's overwhelming, just take it in little bits and pieces or surveillance first. That's what I would say.
Can I add one thing to that? Diet starts with what you're able to chew and not chew. So that's kind of where I come in. If you're making dietary choices because you cannot chew and it hurts to move your jaw, they may not be the best choices. They may not be the worst. But if your jaw hurts and it's affecting your diet, it's going to affect a lot of other things. So again, let's think about this joint. You know, I mean, you can tell people to eat carrots, but if they can't chew them, we got to do something about that.
Okay. Let's see. We have a couple of questions about Spooner in particular. Are there ADS specialists only at specific Spooner locations? Do we offer Pilates as part of our physical therapy for EDS? How useful is water aerobics and exercise for EDS and other hypermobile issues? So just to speak to that briefly, we have several specialists within Spooner who are excellent at treating EDS. Very often therapists who are not well-versed in EDS treatment will seek me out and do a lot of mentorship with me. Either I go to them or they come here to my clinic. So I would be your first place to start, though, if you'd be interested in OT or PT at Spooner. All of those things that were mentioned, Pilates, water exercise, all of that type of stuff, fabulous ideas and fabulous interventions. It will just depend on your specific case and your goals and what we're working and all that good stuff. So that's why it's important that we have an individualized treatment plan for you. Okay, we have a question about tethered cord syndrome. Very fascinating thing. So
with tethered cord, I had an opportunity to work in Phoenix Children, and we did a lot of tethered cord surgeries with pediatrics. And depending on how bad that is attached, it will probably need some type of surgical intervention with a neurosurgeon. My input on that is, I don't know any EDS neurosurgeries, do we? Not that I know of. Yeah. Local. That might be something we could probably look into and see who we can refer to that might be able to look at that. As I've worked with Ronaker on a kids. Is this for a kid or an adult? For peds, so Ronaker would be one who does it. I've worked on her cases as well, monitoring for those specific ones. And then there's the other lady, Bristol. She's another one that does tethered cord. That's very meticulous in doing that. So we monitor the neural pathways above and below that cord so that when we pull that cord back out and cut the tether, we're not cutting other nerves on there. So it's a great procedure. I've worked with it quite a bit when I was there on both of those Bristol's and Ronaker's cases. So those would be the two for kids that I would know of.
awesome. This one that you had here, Linz. How do I help my EDS community as an RN or a BSN or professional, I suppose?
Yeah, so this sounds like a question from an RN looking to help their fellow community. I really like this question. I think it's pretty cool. So I would say RNs are good at care coordination. So kind of what I took over with the roadmap, it's directing people who are lost and finding the best providers to take care of them, or, oh, it sounds like maybe you have some allergies and just maybe check out an allergist or something. So that's how I would help the community as a care coordinator.
Okay, we had a question about orthodontic care and also severe and constant TMJ pain. This person has customized orthotic devices, and they've done all sorts of physical therapy and chiropractic care, but they're wondering if there's anything that they can do to improve their quality of life. Do you want to speak to that?
That's a great question. Let me start with the orthodontic care. Your teeth are held in place by ligaments, which are made of collagen. Orthodontic care is very tricky. There's a lot of relapses. It doesn't always work. I am fortunate enough at the dental school to have one of the leading orthodontists literally in the world as the director of our postgraduate orthodontic program. And he knows nothing about EDS. He never heard of it until I started referring patients. But because he is the kind of person that he is, he said, I need to learn about it. And I can give you his name if you want it. There is no research that has ever been done on orthodontic treatment in EDS and how to make it work, how to make it not work, which should not come as a surprise to anybody. But it needs to be done very slowly, much more slowly than average, because it'll just relapse. Those poor ligaments, they just don't work that well. And if you're going to move teeth on ligaments that don't work that well, they're just going to move back or loosen up. And I have seen some horror stories of people losing all their teeth. So you can get a hold of me if you're in the Valley, but orthodontics is an area that's a complete mystery. We just know it doesn't work very well and people relapse a lot. As far as orthotics go, I can't speak specifically because I don't know who asked the question and what kind of orthotics you have. If they haven't been fabricated by an orofacial pain specialist, a board certified orofacial pain specialist, I can't speak to whether or not they're appropriate. There are some that are very damaging. There are some that work very, very well to stabilize the joint. But in my own experience, and again, kudos to Natalie, it is very difficult to heal a hurting TMJ and somebody with EDS without a good physical therapist to work with. I can't do it alone. So if you have any other questions, will you give them all our contact information since we all forgot our business cards?
I will. Great questions, you guys. Keep sending them in if you have more. This is a question about other providers in the Valley that we work with. There's a few questions about that. Orthopedic doctors and how they play into the care team. What orthopedic doctors in the Phoenix area have an EDS specialty or work with EDS patients? Do we work with Dr. Saperstein, Dr. Crowley? They've mentioned a few different names from a few different questions. Does anybody want to speak to that? Yeah, Lindsay? Huh? What? Want to talk about the roadmap? Explain what the roadmap is in case somebody doesn't know. Oh, okay. Okay. Let's so and then I can jump on it. Sounds good. Okay. So I mentioned the roadmap a couple of times. I guess not everybody knows what that is. So basically, if you come to see Dr. Sharobeem and I, we give you it's 12 pages now of roadmap. And basically it has every single specialty. And it has a list of docs that we know of that are knowledgeable, compassionate on EDS. So it really just kind of helps guide your care. You having a problem with this body system? Here's your list of people to go to. So a big problem is insurance, of course, but you know, we do what we can. So
I'll say one other quick thing on that. Yes, as providers in a specialty, we of course know of and work with other providers within the specialty. Certain providers are, you know, it does depend on insurance and which insurance we take versus which insurance they take and kind of where you're going to end up. That's a whole other nightmare for another day. But all of those other providers that you mentioned, yes, we know of them. Yes, we work with them. We'd be happy to speak with them concerning your care as well. Maybe hopefully that answers the question. Anyone else want to speak to that at all? You want to? Okay.
Oh, sorry. No. Is it this way?
Sure.
All right. It doesn't matter. All right. Sarika Desai for cardiac autonomic issues. I really like her. For some of the patients with a small fiber neuropathy, dysautonomia pattern, I've had a lot of good luck with, oh my God, I'm forgetting his name. Honor Health. Yes, Yazan Al-Hassa. Thank you. He's the man. And then I call her endocrine queen. All hormone problems. Andrea Ferenczi. She seems mean, but she's really sweet. Oh, do you want to? Sure.
No, just to build off that, without kind of going over the list in my head right now with everybody, we do have people that, you know, just are always ready and willing. I want some of my, you know, top referrals, obviously going to cardiology for, you know, the POTS realm, going for histamine and mast cells. I do lean on doctors like Dr. Rachel Bond in the East Valley, Dr. Lowley, although all these specialists can be hit or miss, not because of them, but because of logistics. So understand that whenever we refer to anyone like the, you know, named, we at the moment think that they would be able to handle the caseload, they'll be able to communicate and handle logistics, but sometimes their office staff and sometimes their wait times and sometimes just, you know, general day-to-days can make it a little difficult for one individual to get in and see that doctor or subspecialist, excuse me, and another individual the next day says, oh, I love that doctor. So everyone's going to have their experiences. I have to say, though, I lean heavily on my naturopathic friends in the field, and they have saved our lives time and time again. They're just awesome, and they think outside the box and inside the box and everywhere around the box. Actually, sometimes there is no box. All right. And that's okay.
What's a box?
What is a box? Yeah. Why are we in a box to begin with? I don't like boxes. But I can tell you right now that everybody, again, has a niche. And, we have our friends in, allergy and immunology, even though they might not proclaim and sing from the hills and shout from the rooftops that they know what mast cell is. Some of them do not. They will take it to the grave that they don't want to say mast cell out of their mouths. They will still treat your mast cell. They will still look into it for you because they care. So even though we send you to somebody and they may not have mast cell written all over their websites, trust me when we tell you, at that moment, the conversations we have in the background that you guys don't see, that nobody sees, these doctors are willing, ready and willing to at least look into it for you and look into it for us and just kind of network and connect and see if they can handle it. If they can't handle it, they'll be very honest with you. Sorry. And then you come back to me and, yell at me and stuff like that and tell me, you refer me to a dud, but it's okay. It's okay. It's a work in progress, right? We keep trying, we keep working with each other. And I promise you one thing, I won't stop as long as you don't stop. That's my promise. You keep coming back to me. I'll always try to help troubleshoot with you because like I always tell Lindsay, I have a lot of energy and it doesn't go away. So I will be your energy if you need it. So please use us, exhaust all options, and we're going to be there for you.
I think to play off of that, EDS now is coming into the forefront of all the literature and medical studies at this point. A lot of people don't know what it is. So we're all on the forefront of what it is, how to work with it, what's going on, how do we deal with it on all aspects, where in the 80s, it was one condition, it was another condition until we start to research and find out more about it. So a lot of these times when we go to these doctors, they know a little bit and we have to just get in to work with it, do a little bit of research, find the next one. And it's kind of a game to play or a chess match till we can figure out what we need to do to get in on where it's at. But we are on the forefront to understand what's happening. And a lot of these doctors, again, they don't understand the full factor and picture of it.
Great question. Okay, so big one. A lot of people are asking, where do I send friends and family? Where do I go looking for an EDS diagnosis? I'm having a hard time getting a diagnosis. What would you recommend around the valley, et cetera? Lindsay? Andy.
Oh.
24 hours.
Did I say I have energy? No, that was.
He's 24/7 and he's accepting all new patients.
Oh my God. Rebecca's gonna get me in trouble. But I have to say, I mean, if you know me, if you know the practice, you know that we stopped accepting new patients for Ehlers-Danlos specifically, not because I don't like you guys anymore. No, I love you guys always and forever. You're in my heart, and you're on my mind, but it's truly physically impossible. I'm trying my hardest to network with people that know how to diagnose it as well. But there's so many flavors out there, so many variables. I know Dr. Saperstein is able to, but as you guys know, it's hard to get in when you don't have the funds. And honestly, sometimes doctors that are concierge get expensive. He does it all though, for instance. So once you're in, he'll look into POTS, mast cell, EDS, chronic pain, all of the proclivities, the CCI. He even has these cool machines and doodads. It's everything, right? But you got to get in first. So hurdles like that, hindrances like that, it's unfortunate, but everybody's trying to make their way, whether practitioner, specialist, or patient, right? So what I can say is that, and I'm losing track of what the question was to begin with, but the EDS diagnosis, I wish I can say even geneticists. I wish I can say primary care. I do have friends in the field that have wrote written op-eds and, little articles and case reports about how we're missing that whole piece to this, right? Why is it that you have to go to a rheumatologist who treats autoimmune disease all day to get a diagnosis? Why? It takes everybody who has, osteoporosis to come see me, and it takes 6 months. Imagine if you had Ehlers-Danlos syndrome and then have that triage through the patient service center. They have no idea what it is, and even some doctors don't. So why is it that a subspecialist that treats autoimmune disease, you have to wait for that person to see you first to get, remotely a remote diagnosis? You should be able to go to the primary care physician. They should be able to have the awareness to suggest, hey, I've heard about this. It seems like you have that thing, the Gumby thing, whatever they want to call it. What is that thing? And you're like, Ehlers-Danlos? And yes, it's Ehlers-Danlos. And you kind of feed off each other. And then they can say, you know what? If it's not that, I don't know what it is. That's my dream. Like, I can just stand up here and do I have a dream speech. And that would be my literal dream for the doctors that are on the forefront, the front lines, literally, your GP or PCP or family practitioner, to just stand up and stand up for you guys and just be more aware. And it's not a fault of their own, but we're not exposed to it. But that's my dream, to have the more ubiquitous primary cares. Rheumatologists are few and far between, There's not a lot of us in the country, in the world. They don't even know we exist in Europe. If I go to Europe and practice, I'll be a chiropractor, no offense. But literally, I've looked into it, and they said, you could only be a chiropractor because I know osteopathic manipulative maneuvers. And that is sort of like where we mesh, where we have that area, that Venn diagram, if you will, with Jay. So my dream is to have primary care geneticists, the people that are primary care, to be more aware, to be able to just put that in the chart so that you guys are not bouncing around with all the other nuances of EDS, except for EDS itself in your chart. That to me is just, it blows my mind. So truly, I want to say out of the depths of my heart, I want to see everybody. I want to diagnose everybody. I want to help everybody, but I'm only one person. We're only one team, and it's literally physically impossible. We don't have enough time. That's the truth of it all. I want to be honest. And we had a wait list for 2 years. And right now we still have a wait list to the end of the year. And we stopped accepting new patients a year and a half ago. So this is the issue we're coming up with, we're facing, that we don't have enough people out there that are in the front lines, taking it on, diagnosing, and then directing your care. And we are more than willing to go out into the community, provide the roadmap, provide the awareness, provide the education. And then we can kind of build off that. So we're working on it, but it's a work in progress as always. I hope that also makes sense.
I'll add a little something to this. 2 old timers in my life. One of the old timers said, Bill, you can't do anything until you have a diagnosis. And he was all about, you have it on the paper, you have the ICD-10 code, you have it all lined up before you act. Otherwise, you watch and wait. And another old timer who said, well, good luck, because if God was a rheumatologist, you'd still seek a second opinion. Oh my God, all these things overlap and do this, that. This looks like all the zebras and lizards, right? And I don't say that to discount the importance of a diagnosis. It's very important. There's a lot of reasons to have the diagnosis on a piece of paper. But I see a lot of patients, they come in, maybe the issue is rheumatologic or endocrine or this or that, and they come to me and they go, what do I have? And I'm like, I don't know. I'm not that smart. And you've seen like 20 people smarter than me, but like, let's narrow this down and what seems to be the most plausible thing. And are you comfortable with me or these other people on your team just operating off of a hypothesis and diagnostic trial by fire, taking action instead of waiting to get the diagnosis? The Baton score 9 out of 9, the genetic markers, the full house panel for lupus, rheumatoid arthritis, whatever, because the clock's ticking and you guys got a lot of life to live. And so, back to what you were saying, don't discount who's already on your team. Half the time I learn something new, it's from either patients who learned about it themselves, or they badgered somebody on their team, their primary care, whoever, with articles saying, hey, here's a Candida book, or look at this thing on MCAS. And I had a story like that, which actually inspired me to get into playing around with allergy methodology for MCAS. And I saw this gal, I think you were involved in the case too. Put her on LDN, changed her diet, did all this stuff, did some DMARDs. And then I saw her 2 years later and I'm like, what the hell happened to you? You look like a new woman. And she found some like allergy guy she badgered to put her on triple therapy for MCAS. And she was like a new woman. And she didn't have a diagnosis of EDS. I mean, it was a putative diagnosis that everybody was talking about, but there were no genetic markers. It wasn't on the piece of paper. She said, I'm sick of feeling bad. Let's go. Let's dance.
We're going to just do one last question, and then there's so many more and they're so fabulous, but we're just going to do one more and then we'll have time to mingle. You guys can meet each other if you want to introduce yourself to anybody in the room, and then we'll all be available to speak to you one-on-one for a period of time for questions too. But the last question I want to address, a few people have written in about just the best way to manage pain in general. What does this one say? The best way to get general pain relief outside of PT. Maybe that's specific to pharmaceuticals or other types of pain management things. Anybody want to speak to that, Jason?
So if you want to look naturally, you can start with naturopathy. You can look at glucosamine. They found studies that glucosamine itself helps stabilize the joints and ligaments, and 1,500 milligrams or more a day is equivalent to 400 milligrams of ibuprofen. So that could be something natural that won't mess up your stomach. Curcumin, turmeric, changing your diet, other anti-inflammatories that you can look at. From a standpoint from medications, there's always medications depending on what the underlying cause of the factor is. We've talked about a lot of the mast cell and inflammation. And some of these natural things that may not help, we may have to step it up a notch. So trial and error is a lot of it, what's happening at this point in time. If it's more pain, then we look at more pain management. And what does that look like? Is it just a pain doctor doing injections? Well, maybe if it's arthritic type stuff, that might be an option, but are we ready to go down that road yet? Or have you been educated enough to understand what it's looking at so that you have a better understanding of, hey, when I get this steroid injection and it doesn't work, but I had relief for an hour, we know that we're targeting the area, but the steroid's not in the right area, or there's no inflammation to knock out. So that may be not the best treatment that we need to work on at that point in time. Or is it a joint? Do we need to immobilize it for a while and do some PT? So there's a lot of different things that's out there. It's all case dependent on what needs and what the factors are.
Also briefly, really important to, I know you all know this, but advocate for yourself, understand what your body needs, what it doesn't need. And if you don't understand that, find a provider that can help you to figure that out. I find with my patients that a lot of times some of the best pain management things are outside of the realm of typical PT types of interventions, meaning we work on a lot of like vagus nerve regulation, dysautonomic regulation, a lot more personalized perspective than just simply telling you to go on LDN, to go on all these other things. That can be really helpful tools, but like what does that person need for their specific body and nervous system? Our pain is such a complicated thing. It's never just biomechanical. I'm sure you're all aware. So that's really important to me, that we figure out what types of systemic approaches we can use with you in congruence with lots of the other things that you might have from an outside perspective. But where can we target your nervous system to be able to help you feel better and have less pain?
So I deal with chronic pain all the time, from the neck up. And I have a lot of conversations with my patients about dysautonomia and breathing. Most of us breathe improperly. So if y'all go home and just Google diaphragmatic breathing and watch a YouTube video, the diaphragm is the giant muscle that separates your lungs from your abdomen, and the vagus nerve runs right through it. And by breathing properly and using your diaphragm, not only are you increasing lung volume and increasing oxygenation of all your cells, you're also regulating the vagus nerve. And mindful relaxation. You don't have to live in Sedona to get all this stuff. I mean, this stuff really works. And, you know, I'm sitting next to a naturopath, so I know he agrees with me. Whatever you need to do to mindfully relax, whether it's listening to music that you love, it doesn't matter what it is. There's plenty of science that if you love music, it doesn't matter what it is, but if you love it and you just close your eyes and you listen to the music, it totally changes your endorphins and your brain chemistry. And for people who can't sit still long enough to meditate or have trouble getting the thoughts out of their head, listening to music is great. There's all these, yes, there are medicines and the medicines work wonderfully, but there are ways that you can empower yourself to manage it. And if anybody else wants to add to that.
I like those ideas. Those are great. And I want to add another thing about the nervous system. First one, plug for Nerva, which is an app for visceral hypersensitivity, because I got asked about diet. Okay. No financial ties, but remarkable for some of the patients. It wasn't really the food. It was their enteric nervous system, right? Second brain, right? And so, yeah, great. Awesome suggestions of stimulating your vagus nerve, but also think about what you're feeding your nervous system every day, right? We live in America. I don't like you if you like Tucker Carlson. I don't like you if you like Don Lemon. I don't like you if you're this or that, right? Feeding yourself bad news, bad vibes, bad energy. We all have to deal with it in our interpersonal circles every day. Nobody's excluded from it. But, you know, it's okay to hang up the phone sometimes and say, Sam, Sally, Sue, I love you, but I just don't have enough bandwidth for it today. And then I'll call you in a week. Bye. Click.
Turn up the music.
Yep. So these are wonderful like suggestions and interventions. And of course, when you're talking about pain, it is subjective. It is something that you're dealing with and nobody else is dealing with. So you have to kind of dichotomize it also to acute on chronic pain, right? Chronic pain is extremely variable. It can come from different directions. There are people that have to work on leaky gut and bacterial overgrowth to get rid of their pain. There are people that have to work on their histamine regulation to get rid of their pain, or at least subdue it enough to have quality of life. And there are others that suffer from CPTSD, PTSD, other forms, where all you're left with is I got to do that rapid eye thing with my psychiatrist, or I got to go and think about my childhood again and rip through that whole kind of trauma. All of this can amount to dealing with your chronic pain. Acutely, that's a little different. Sometimes flares are flares. Unfortunately, you can try to kumbaya the whole thing out of the way, but it'll just stick with you no matter what you do. I even tell my patients, Lindsay and I always talk about a flare toolkit, even as simple as IV fluids. Most of our patients, they do not absorb things right. They don't distribute their water intake right, their electrolytes right. You don't know how much sodium you should take sometimes, Is it causing my blood pressure? Is it actually keeping me upright? What element T, Ultima, whatever. So do I drink caffeine? Do I not drink caffeine? Do I have to be on a stimulant? Can't be on a stimulant? I can't, because it messes with my heart and my blood pressure. So all of these things, it's like a fine art, unfortunately. And you are now like building off that to become a masterpiece of your own. But it takes a lot, Michelangelo just chiseling away, and until you get to that masterpiece. And sometimes it's growing pains, literally and figuratively. And when it comes to that acute on chronic, you have to know what is your thing. Go back to the thing. What is your thing? What gets you out of that stuff when it's gotten you out before, And so you have that path, you have that journey of healing. It is slow, grueling, and so annoying. And you wish you could have instant gratification every step of the way. It's just not in reality. But you have that circle, you have that support, you have the people that care, you stick to that, you advocate for yourself, you fight for yourself, take it one day at a time. You just fight, because what's left to do, right? No one's going to fight for you as much as you're going to fight for yourselves, right? So fight, fight, fight. Don't stop, because we're not going to stop either. Okay.
Very last thing, we will put the roadmap. We'll get you all the roadmap. All the people online are asking in all caps. Everyone online wants to know where to find the roadmap. So we'll provide the roadmap for all of you. Okay, awesome. So lovely, wonderful to see you all here. Please stick around. Feel free to come up to us with any questions. There's a lot of really specific questions about specific things, so please ask us. Feel free to meet and mingle each other. And cheers to all of you guys. We will provide you with a link in the email that you provided us with when you registered. And if you didn't fill that out, please make sure you see me tonight so you can give me your email address so you can get that information. Okay.